Okay, yeah. First of all, I'd like to talk about the origin of growth plate during embryonal development. Long bones are made from cartilage model, where primary and secondary ossification centers develop and make bone tissue by endochondral ossification. The growth plate is a remaining cartilaginous tissue between the primary and secondary ossification centers, in which endochondral ossification continues until skeletal maturity. The growth plate is composed of chondrocyte columns in zonal pattern: resting cells, proliferating cells, hypertrophic cells. Hypertrophic chondrocytes undergo calcification, apoptosis, and is replaced by primary spongiosa. When sustained physeal injury, a breakage develops through hypertrophic zone at the junction of the calcified and uncalcified parts, which is the weakest zone. The growing chondrocytes remain at the epiphyseal side, theoretically undamaged. It means that if the breakage takes place clearly at this zone, the growing potential of physis will be maintained. Then why does physeal arrest happen in some cases of physeal injury? Here, I'd like to stress that we have to differentiate two terms: physeal injury and physeal arrest. Physeal injury is a traumatic condition that involves the physis. On the other hand, physeal arrest is a condition in which a whole or certain part of the physis lost its growing capability as sequelae of physeal injury. So not all the physeal injuries result in physeal arrest. There are several mechanisms causing physeal arrest. First, the metaphyseal beak may crush the physis, as in the figures, during the injury or during reduction procedure. Second, the physis is not a flat structure three-dimensionally, but it has undulations. So the growing chondrocytes can be crushed by this undulation during displacement. It happens commonly at the distal femur. Third, the physis can be crushed vertically by compression force, resulting in physeal arrest. The physis can be missed partially or as a whole by open wound, causing physeal arrest. It was described by Dr. Rang and Dr. Peterson. In some anatomical locations, a physeal injury can cause vascular insult to epiphysis, stopping nutrition to the germinal cells of physis. Proximal femoral epiphysis and radial head are the examples of this kind of location. Several classification systems have been suggested, and Salterhead's classification is the current standard classification system. Drs. Salter and Harris published their classical paper back in 1963, classifying the physeal injuries based upon mechanism of injury and relationship of the fracture line to the growing chondrocytes. Type 1 is caused by shearing and aversion force. It is common at birth or early childhood. It is easily reducible and usually gives excellent result. Type 2 is the commonest type. Triangular metaphyseal fragment called Thurston-Holland sign is the radiographic hallmark of this type. The periosteum on Thurston-Holland fragment side usually remains intact, while the periosteum on the other side is torn and stripped from the metaphysis. Type 2 has also excellent result in most cases. Type 3 is an uncommon intra-articular fracture, so accurate reduction of the articular surface should be done. Type 4 fracture also requires accurate reduction at both articular surface and physis. Unless accurately reduced, a bone bridge may be formed between the epiphysis and metaphysis, causing physeal arrest, and joint incongruity will ensue. Type 5 is caused by crushing, usually at the weight-bearing hinge joints like ankle or knee joint. Severe abduction or adduction force in these joints may cause this type of physeal injury. It may be misdiagnosed as sprain, because there is no stigmata on X-ray. Physeal arrest is almost inevitable. Dr. Rang from Toronto Sick Kids Hospital described other type of physeal injury. It is a traumatic defect of the perichondrial ring or John of Ranvier. This injury does not belong to any types of Ortho system and may produce peripheral bone breach and cause angular deformity. The injury could be a glancing type, apparently not serious, for example, a cut by lawnmower. The most common type of Ortho system is type 2, followed by type 1, type 3, type 4, and type 5 is quite rare, but it must be underdiagnosed to some extent. Distal radius and distal tibia are the two most common locations of physeal injury. Dr. Ogden from Yale University presented further subtypes and additional types to Ortho system. For example, he subclassified cases in which metaphyseal beak crushes the growing chondrocytes as type 1C and 2D. However, they are theoretical subtypes and usually difficult to detect by initial radiograph. Comminuted fractures were further subclassified as type 2B and 4B. Open reduction and internal fixation are needed in most cases. He also added type 7, which is a pure epiphyseal fracture. This does not involve the physeal, but may interfere with the epiphyseal growth. In 1993, Dr. Peterson from Mayo Clinic added an important type of physeal injury that does not belong to the Ortho system. It appears to be a metaphyseal fracture, but has extension to the physeal. As a result, it has a risk of physeal arrest, although it is not so high, only 3%. However, it is important to take this risk into consideration from the initial management. Several factors predisposing to physeal arrest have been suggested. Ortho type 4 and 5 have significantly high risk of physeal arrest. Severely displaced fracture, open fracture, fracture of epiphysis with poor circulation, such as femoral head and radial head, have higher risk. Forceful reduction and prolonged fixation across the physeal are iatrogenic factors predisposing to physeal arrest. Finally, younger patients have more growth potential, so they will have serious consequence from physeal arrest, if ever. I'd like to close my talk stressing that Ortho has 5 types, Rang type 6, and Peterson type 1 have therapeutic and prognostic significance. Management should be guided by the injury types, and further damage to the physeal should be avoided. Thank you for your attention.